That's a very important topic, and we've heard some of these conference already starting with the plenary session from Dr. Mesa about the symptoms. So we have a currently established scores for treating versus not treating patients with ET, where the standard high-risk patient would be those older or those that had a previous thrombosis. But those are to prevent another thrombosis. You don't impact the long-term disease behavior. We kind of abandon and look away from symptomatic patients, from patients that will be progressing other ways. Then there are criteria for starting therapy that would be beyond aspirin in patients with extreme platelets, in patients that would have otherwise other concerns or symptoms. But I think that's not that much addressed, that there could be extremely symptomatic young individuals that would have looking almost normal counts, but have extremely poor quality of life. So we use a standard stratifications where we basically treat everybody with aspirin except for people with extreme thrombocytosis or specific criteria. And then we use cytoreduction for high-risk patients, either the older ones or those that had a thrombosis. And then in the specific circumstances, people will have more symptoms, or they would have extreme thrombocytosis, or otherwise uncontrolled, rarely splenomegaly, but we could see whether some patient would fit these criteria.